Thank you for joining us for today's webinar, Progressing Forward in Relapse Prevention, Dealing with Stigma. My name is Marla Kaufman, and I'm the Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. I would like to go over some quick housekeeping items about how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar through a few methods. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Samson Teklemariam, will take questions at the end of the webinar. Feel free to submit your questions through the chat or Q&A box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check your attendance with WebEx following the webinar. After the webinar, you'll receive several follow-up emails. The first will be an email that will include a link for an evaluation form for the webinar, as well as information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Samson Teklemariam, LPC, CPTM, is an industry thought leader with a track record for leading large-scale transformations that generated new thinking, shifted business models, and disrupted the marketplace. As a catalyst for innovation, Samson constructs clinical leadership models designed to navigate change in the healthcare sector and deliver results that improve quality patient care. He was formerly the Director of Training and Professional Development for NADAC. He is a certified lead trainer for the Cognitive Behavioral Interventions for Substance Abuse, CBISA, and experienced in treating trauma-related disorders using trauma-focused cognitive behavioral therapy and seeking safety. Okay, Samson, if you are ready, I will pass things over to you.
Thank you so much, and thanks, IRETA, for setting this up. I'm so excited for you all joining us today on our talk about progressing forward in relapse prevention, dealing with stigma. So as they mentioned, my name is Samson Teklemariam. I'm the Vice President of Clinical Services for Behavioral Health Group. We're a national organization that provides outpatient treatment and medication-assisted treatment throughout the U.S. Before we jump in, I want to really be upfront with you about my why, and I would love for you all to share your why in the chat box if you're here joining us live. If you're watching this as a recording one day, write down your why before you jump into the content. There's a reason for it. So here's my why. In 2014, SAMHSA and NADAC joined on a survey of addiction professionals and their journey into the field. The results of that survey showed that 68% of those in our field, in the addiction treatment profession, acknowledge that they themselves are in recovery. I call this group professional helpers in recovery. Now, if you've been in this field for more than 10 minutes, that doesn't surprise you. From state to state, program to program, we usually see a really even mix of professional helpers in addiction treatment settings who they themselves are in recovery. Some choose to disclose, some maintain it privately. And we see an even mix of those who are not, but may have a variety of other reasons working in this field. Around the same time of that survey, I was really fortunate to be working closely with an even representation of experts in our field, some who were in recovery and they were my supervisors, some who I may have also report to, but they were not in recovery. Now the ones that really stick with me achieved incredible professional growth in our field, director level, C-suite positions, and they were themselves in recovery, a champion in our field, as we know. I personally witnessed 3 very memorable times where a very high-level leader in recovery experienced what we call a return to use or a relapse. And in each situation, the treatment organization decided to part ways with that individual as a response to their return to use. At the time, I kind of felt alone in my feelings because I was infuriated. Everyone else kind of accepted it as a norm. Like, yeah, that's what happens, you know? Um, but I remember being really confused, kind of frustrated. There were times where I called out our field and hypocrisy, um, and something that stuck with me is each of these leaders were so far along in their recovery, they didn't react the way I did. They didn't share that anger. At least maybe they kept it close to the chest, right? They did a really good job of owning their responsibility. They got the care they needed, and regrettably, they moved on. I'm proud to say that today our industry has really made incredible progress, but we have a long way to go. We need to progress forward our paradigm of care so we're ready to take care of our workers just as much as we take care of the communities we serve. Now, I want you to think about your why. You saw this topic, you saw the title, and you said, I'm going to take this. I mean, what was it? CEs? Is that it? I mean, was there something about the topic, a word that jumped out at you that said, oh, yeah, yeah, that's why I want to take this? So go ahead and write down your why or type it in the chat box. Okay, so let me give you the roadmap of what we're going to discuss in this short time that we've got. These objectives may not necessarily flow in a linear fashion. I hope to achieve each objective by building along the way. So we may jump around a little bit, but just so I could show you the boat before we build it together, here's the answer to the test. A progressive paradigm in relapse prevention for a chronic medical condition like substance use disorder requires three things from us as professional helpers, as leaders, as advocates, and yes, as scientists of the field we work in. First, we must start looking at relapse through the lens of the neuroscience of addiction. I'm talking about that risk reward mechanism, okay? We'll chat more about that later. Second, we have to deal with stigma. And yes, we have to acknowledge that stigma may never be fully dealt with, right? Third, we have to make a choice to become a recovery friendly workplace. It all starts with us. Okay. Thank you, Randall and Walker in the chat box. A couple of you are sharing your why. Clients and friends who've relapsed, some of whom did not survive the relapse. That's right. It's a dangerous disease we're working with that quite often can result in someone's mortality. So let's do some word association in the chat box. I want you to share what pops up in your mind when you think of the word relapse. If you can, try to keep it to a phrase or a word. So just a little word association activity. I say relapse, you think what? And if you're having trouble thinking of a word, all right, so consider what words in the history of addiction treatment or your experience in our field have typically been associated with relapse. Okay, so we got some here. Thank you, those who are responding in the chat box. I see dealing with stigma, slippery slope. Oh my gosh, yes, I remember that, Suzanne, too. Addict, disappointment. Sydney, part of the journey. Thanks for sharing that, Sydney. Reoccurrence. Yes, Mariana. Yes. Clients who have relapsed after a long period of staying addiction free. Okay. Setback, old behavior, regress, dirty, spiral, crisis, shame. Oh my God, y'all are filling it up. I can't catch up. There's a lot of the chat box. Someone take a screenshot of this. Struggle, going backwards, falling on your face. I've heard some of these. Some of these are new. I haven't heard that. A slip. Yeah, yeah, I've heard that one. Slip. Reluctant to recover. Interesting. Okay. Okay. Yeah, so that's right. Notice the long list, the diversity of responses from your peers, from your colleagues. Thanks, everybody. So words do matter, especially in our field. We always say anything from the DSM is the dismissed part of healthcare, right? And from the DSM, anything related to addiction and substance use, we know is even more dismissed or stigmatized. Our patients are drowning in experiences of stigma, misunderstanding, and a lack of acceptance, not just in their homes, in their neighborhoods, their communities, but also in the helping profession in healthcare. There are certain words that are triggering, right? And some of you shared them clean. So what? dirty before? Am I unclean in a spiritual sense? If I use again, does this mean I need a bath? Should I use Dove, Irish Springs? Does it depend on the route of administration? I've shifted from inhaling to injecting, or maybe I've leveled up or stepped away and no longer injecting, but I'm using inhalants or I'm using a patch. Right? We have clean, dirty, addict. If you studied earlier works of CBT and SUD treatment, you may have also read about one of these here, the abstinence violation effect. It's not used as much anymore, but it's sort of matured or graduated into understanding a lapse versus a relapse. A lot of words here, right? Regress, fallback, remission, sobriety, break. The list goes on and on and on. And some of the language has come from the people we serve. They come in and they use these words. But there's inconsistency in the field, right? And sometimes we don't know what to say. We don't know what's right, what's wrong. We don't know what contributes to my patients feeling accepted in recovery and what might contribute to my patient feeling rejected or dismissed or stigmatized. Now, let's go to the history, and this is really a lit review. I'm going to give you just a couple of slides of what we've researched about substance use and return to use, relapse. Now you'll see me use return to use often. That's what I'm preferring to use today, but I'm going to keep learning. I'm a student of the field. But you will also see me interchange between these words, and some of that's intentional. Now, substance use disorders are often defined as a chronic illness involving a common repeated cycle of abstinence and relapse. Interesting definition, right? Note that there's an understanding at the point of entry into our field or at the point of diagnosis into treatment that this illness you're being diagnosed with includes remission as an expected norm. Take a moment and think about that. It is in the definition. If you spend some time digging through systematic reviews of current literature, you'll learn that the most common definition of relapse is a return to a previous level of substance use after a period of considerable reduction or abstinence. But what you may not find consensus on is how to really conceptualize relapse. You may not see a consensus on how to apply specific time criteria. I mean, think about the definition, right? So see if I could hover my mouse, a period of considerable reduction, vague much? I mean, what does that mean? What is considerable? Considerable for me, maybe 7 days. Considerable for you, maybe 9 weeks. So what is considerable, right? I mean, how do we really measure that? So now, what you'll see in some studies for early relapse, they use the word early relapse in a lot of these research studies. You'll see it referring to 2 to 6 months, while others are saying 3 to 12 months, so up to a year would still be considered early relapse. Now, for late relapse, some studies used 18 months, so over a year, while others used 3 years. Now, you'll see a small citation at the bottom here, but you can actually go to the references slide, and the slides are also going to be shared as a resource or as a handout. In the last slide on the references slide, I would really encourage you to push a little bit, dig a little deeper, look at the review of literature and some of the other measurements they use. Now, some alternative definitions. Recurrence or just overt avoidance of an actual defined term. Now, just defining relapse is a few studies I saw that I really liked. They define it as an absence of abstinence. Okay. I mean, if you're like me, it's like, what? Riddle me this, Batman. That's my point, right? What's in a name? Um, no, I'm not a Shakespeare fan. But if you don't know, Google what's in a name. For those of you who are like me and need a little bit of distraction, go ahead and Google what's in a name, Romeo and Juliet. You'll learn something cool. Okay. So how do we even really measure relapse when it happens? When the patient's sitting in front of me and it's occurred, how am I measuring this experience? I mean, are we thinking about measurements? How much did they use? How many milligrams, grams? Are we thinking about how far did they go? How many hours were you under the influence? Now, time has different concepts. How long has it been since the last, right? So I haven't seen you in a week. You had a return to use last Wednesday. You spent 3 days in a ER or detox unit. Um, we used to say, how long have they been off the wagon, on the wagon? Yet another one of those seemingly irrelevant words or phrases. Maybe it's use, meaning what exactly did they use? Was it their primary substance? Was it their secondary substance? Was it their tertiary substance? For those of you who have been in this field for a while, we used to respond differently to those, right? We would say, okay, well, yes, it's problematic that you used your secondary or tertiary, but at least you didn't go to your primary, right? I mean, okay. Was it a replacement? Behavioral addiction or process addiction, or the one that seems to be mentioned the most, I'll say the most consistently, is the two words amount and frequency. You'll see by just a little bit here, 27%. Now, in other words, what amount did they use, and what amount was found in their system in that UDS screening, and how frequent did they consume or inject? Was it a behavioral lapse? We'll talk about lapses later. Or it was a one-time thing and they immediately said, oh my God, what am I doing? And they came to you or they came to a doctor. Now, in our field, we also look at a few other things. I joked earlier, but a less risky route of administration we may document as something that is showing marked progress or marked response towards safety. Did this person experience less negative symptoms, more positive symptoms? Were there consequences based on societal construct, like legal, social consequences, family loss, my third, fourth time in the ER? Now, again, I want to be clear. I'm not actually challenging the norm here. Not yet. I'm not challenging the norm yet. Each of these measurements are heavily researched and very reliable. So there's nothing wrong with us looking at these because there's a lot of validity behind how we are defining it. Most patients, if you'll see them present with some, if not most of these areas as objective norms associated with that experience of returning to use. However, this is really just a skim. It's a small review of the current literature. I added the citation here so you can really dig in. But for me, this means something. Inclusive data or data returned to us in the field that doesn't prove or disprove a hypothesis is still very useful information in the research world. Now, for me, I think this means we really do have a choice on how we treat people in this field when it comes to a return to use. We have a choice in how we treat our patients and how we treat our fellow professionals in recovery. All right, so next I have a brief 5-question polling survey that I'd like you to participate in. It's going to show up all at once, and I'm going to turn it over to Iretta to someone from Iretta to chat about this. Oh, it's popping up already. Take a few moments here and answer these questions. I'm going to go on mute. We'll give you about a minute, and I would love to hear your thoughts, see your responses to this poll.
All right, I can see how many people are in progress, so I'll just give it another minute while people are finishing up. Okay, there are the results.
Awesome. Thank you so much. Here, let me see if I
Very
can.
well.
Oh, okay. I think I could see it bigger now. It looks like for the first question, which of the following most closely describes you? 18% here said, I am a helping professional in recovery. 21% said, I am a helping professional, but not in recovery. 14% said, I am a helping professional, not in recovery, but I live with or have a close one who is in recovery. Thank you so much for that. For question 2, I have witnessed someone in recovery being judged and treated unfairly due to their condition. More than half, so 51% of you said yes, you witnessed this. 1% said no. Number 3, I have witnessed a recruiter or a hiring manager ask personal health questions regarding an addiction professional's journey in recovery, like how long they've been in recovery. 22% said yes, 27% said no. Question 4 said, I believe that if someone wants to be a helping professional, they must be in recovery for at least 24 months, abstinent for 2 years. 17% said yes. 27% said no. The 5th question, the last one, I believe if someone is a credentialed addiction treatment professional who is working in our field and is on methadone or buprenorphine, they are not qualified to work in our field. 5% said yes, 37% said no. Thank you guys so much for participating in that poll. Iretta, I don't know how to hide it, so I hope it's hidden, but or you've closed it, but you can
Sure,
close it now.
I
Okay.
can close it now if you don't need it anymore.
Yes, thank you so much. Thank you so much. So yeah, so very interesting. Thank you guys for participating in that. We're just going to kind of set the tone, I think, for where we're going next. So, in addition to behavioral or some of those observable measures that we talked about, we also have to start looking at relapse through the lens of the neuroscience of addiction. Really, what I'm talking about is perceiving relapse through the lens of neuroscience. We're really forced to understand relapse as a risk reward mechanism, not a moral failing. People return to use because it's rewarding or fulfilling something, a need, a feeling, an urge, a desire, right? When we really examine neuroscience and we connect it to behavioral mechanisms, we in plain English, we say, this is helping to solve something for you, to fix something for you, or to alleviate something for you, right? It's either adding something that you feel like you need or want, or it's taking away something that you don't want, don't need. So now what I'm going to do here is I'm going to turn this over to a short video that I brought in for you. This is Dr. Cody Brooks, Associate Professor of Psychology at Denison University. He explains the neuroscience of addiction and relapse in a really interesting way. I'm going to ask you to, as you're watching this, just maybe take a couple of notes on what your takeaway is. Feel free to drop your takeaway in the chat box because you may catch or hear something that someone else didn't catch. And then we'll really quickly debrief at the end. This was actually on a PBS, public broadcasting network, on this topic. So here's a quick excerpt.
Relapses are almost irresistible. Chronic drug use is a complex experience in which, for many users, massive amounts of very stimulating substances enter the nervous system and change permanently the way that neuronal systems act. In much the same way that you or I might acquire a permanent memory about something else in our lives, where we live, the names of our children, things like that. And we very seldom forget those. That's the way permanent memories are. Drug use changes the brain in a way that's fairly analogous, we think now, to the way that permanent memories about other aspects of life are acquired. Going off of a drug doesn't necessarily mean that the brain resets to the way that it was before people started using drugs. So trying to quit is very, very hard because the brain is basically saying, hey, you were giving us this stuff before. We still need it. And I think that's one of the reasons why relapses are very, very common. A lot of my research suggests that relapses happen after people have perhaps tried really vigorously, very intentionally, to seek and get treatment, to learn strategies for dealing with this change in their nervous system and brain in particular, to cope, people tend to forget those things that they learned during treatment. So we have a lot of data that shows, yes, pretty clearly, that stressors make relapses worse. In spite of that, or in the face of that, we've also been able to show pretty systematically that reminders for a treatment phase in an individual's life can still minimize the impact of some of those stressors. Treatments don't necessarily cure. They don't necessarily completely eliminate the remnants of some problem or challenge or mental illness that people have, but they overlay new information, new strategies, new behaviors. I think there's really a sort of a constant struggle of treatment, relapse prevention, harm reduction against the original addiction processes.
All right, so let's debrief. I know that was a lot of information, but I tried to keep it in an excerpt, kind of compact for you. In the chat box, feel free to drop any takeaways that you had. I'm curious, what you kind of caught. I always catch something different when I listen to this. Now, here's some of mine, okay? Did any of you notice when he spoke about how drug use changes the brain, he said in the same ways that permanent memories about other aspects of the life are acquired. Wow, permanent memories, meaning it's not necessarily going to go away, especially that first, second, third time. Now, we know in this field, we can modify our reaction and our sensitization to certain stimuli, right? That takes a lot of time. It takes some work. There is trial and error, but the stimuli itself, the memories attached to it, they often don't just vanish as much as we would sometimes like them to, right? A couple of other things. He shared that relapses happen after people have tried very vigorously, very intentionally to get treatment and learn strategies to cope. Kind of against that myth that when someone has a relapse or return to use, they weren't trying hard enough. Quite the contrary, right? They were most likely trying as hard as they could in that moment. There's a recognition from that video that Dr. Cody Brooks shared that life stressors, yes, they're a trigger, and under stress, it's easier to forget the strategies you learned in treatment than it is to forget those permanent memories that are kind of attached, memories of these effects of drug use, what it actually did for me. So when looking at the risk reward mechanism, when understanding the neuroscience of addiction, you really start to kind of dissipate that perspective that this is all behavioral or it's all moral. You did this because you really don't want it. I'm looking at this UDS result, and this is exactly what I told you would happen. Now you got to start all over again, right? Awesome. Some folks are sharing their takeaways in the chat, y'all. Great. Please keep them coming. I've got a few more videos for you that I'm going to share later. But for now, I want you to think about this. When we talk about stigma, here's a short list of what patients with substance use disorders tend to get when there's a return to use or a relapse. As you look at some of these words and some of the words you shared earlier in our word association game, it's certainly not the same list or experience that someone who previously had, let's say, for example, skin cancer. They go on a family vacation, they forget to bring their sunblock that was most likely prescribed for their condition, and then they return to a primary care provider after that family vacation, and they're in need of additional treatment now related to skin cancer. Now, it's not the same experience that someone, let's say, with diabetes who appears suddenly in the ER in a glycemic crisis. That's not the same that they receive. Even let's say you work with a massage therapist, a chiropractor, or someone who helps you manage back pain related to a surgery. This person in the healthcare industry has probably told you 100 times, stop taking jobs that require you to lift heavy items. But you come back. You need treatment. Something happened and you took that job. Now, you know what they give you? They give you compassion. They give you care. They give you concern. They give you treatment. And yes, sometimes they give you a balanced discussion about the risks of continuing against medical advice and treatment, sometimes more treatment. But they don't get this list. Now, here's the obvious list of what we know our patients need, right? I'm just going to do a back and forth here. They definitely don't need, no more medications for you. You screwed up, a loss of privilege, a loss of rights, a loss of a phase, having to start over again, a loss of control, additional shame, guilt, restricted access to their meds. What they actually need is more support, more guidance, evidence-based treatment, affirming responses, and yes, normalization. I mean, remember our definition earlier of substance use disorders? Isn't a return to use technically a part of the diagnosis? It's an expected norm. They need that objective discussion. That's the part we own. Is yes, we still can and should have an objective discussion with them every time about the risks of continuing against medical advice or continuing use and continuing the risk, right? So you give them that objective discussion, but they need compassion. A lot of times that return to use, by the way, is just a validation that we've got the right diagnosis. I mean, this is, that's a symptom. So let's take a moment now, and I want to dive deeper into stigma because that word was in the title for a reason. Stigma specifically in SUD treatment in our community, our industry. I think there's a tendency within our industry and within the communities we serve that when we talk about stigma, we view this as a them problem, right? We're not the problem. It's them. Who's them? What I mean is it's the community. It's that person's family. It's their parole officer, the criminal justice sector. It's that drug court, that judge that just won't let this patient go. It's general healthcare, that doctor, that pharmacy that treats them that way when they come in. It's society. It's what our patients experience out there, but not in here, right? So I want to challenge you to consider how much influence we actually have on our field and how our field is perceived in society and the patients we care for. I want you to consider that story I shared earlier about my why. What if there are elements of stigma, let's call them blind spots, that we all have that contribute to the perception of SUD care? The reality is, it would be kind of naive for us to think that we as individuals are not also influenced by these societal messages coming at us or these personal experiences that may have shaped the way we feel and the way we think about drug using behavior and people who use substances. Certainly, we're all exposed to media. I just finished a Netflix series, so I'm in the show hole. We know that negative portrayals of people who use drugs is really common in the media. I mean, it's rarely poised as a positive, diagnosis. I'm sure you can all, in about 2 seconds, think of a movie, a TV show, an advertisement recently that gave you a very stereotyped image of a person who uses drugs. Now, if you're human, and it's very likely that you've been influenced by that imagery, by that societal pressure or stereotype. If you're a person who's used substances yourself, you're a person or professional in recovery, these portrayals may have shaped your self-image, even in how you see yourself or how you saw yourself, how you thought about who you are as a person who once used drugs. Maybe you experienced some self-stigma. Maybe you've internalized shame about your own condition. Maybe you've been shaped by your own pathway to recovery, and your blind spot is that alternative pathways can't work as well as the path that I went on. Maybe that blind spot is because someone else caused emotional harm to you by their drug use. Now, I want to ask you, based on the treatment we provide to others, isn't it fair to assume that some of those experiences may have shaped the messages that we adopt or that we understand when it comes to substance use disorders. Whatever your experiences are, we have to acknowledge that we're not immune to developing bias, whether they're conscious or unconscious. I saw someone drop that in the chat box. When it comes to people who've used substance use or used drugs, we could have conscious or unconscious bias, right? Even in this field. Not only should we, as addiction treatment professionals, acknowledge that we have these blind spots, we also have to commit ourselves to a career of checking these blind spots. It's not an activity, it's a lifelong process, it's a journey. I always say the safest professional helper is the one who's committed to lifelong development of self-awareness. Unchecked or unconscious biases towards people with SUD influence us in multiple ways. It could influence our attitudes towards our patients and the language that we use when we talk about them or with them about their behaviors. Think about when a patient isn't making progress. They've missed appointments, they've kind of consecutively missed sessions. Do we still call them non-compliant? Or do we reflect on what they may be communicating to us through those missed appointments? Dr. David Mealy has my favorite quote on this. He calls it voting with their feet. So this is kind of like whether they feel that treatment is actually helping them. Now, if you interpret your patient's most recent episode of use as a failure, how does that leak out in your interventions? How does that leak out in your case review, in your documentation? Don Coyas, member of the Mohican Nation, president of White Bison, co-founder of the Wellbriety movement, who will also be at this year's 2023 NADAC annual conference in Denver, Colorado. He has this quote that has stuck with me. He says, "Words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed." So what does our language convey to our patients about our beliefs and about people who use substances? When a patient experiences a return to use, what's our response? We're sitting there, positive UDS in our hand, the patient saying, "I don't know what you're talking about." Right? Like we've all, hopefully, if you've been in this field, you've experienced that. I've experienced it. You see the results and they're saying something different. So what's your attitude, your response? Is it one of frustration, mistrust, suspicion that they're lying? Or is it one of compassion, curiosity? Is your response maybe even a self-reflection together as a team with this individual that maybe the behavior is telling us something about the health of the patient and the health of our therapeutic relationship? Unchecked biases influence treatment planning recommendations. It could look like minimizing the need for intensive services, making assumptions about our social support. Maybe we're focused and kind of have the guardrails up that there's no other pathway to recovery. So I'm not going to recommend medications to them. I'm not going to recommend a different pathway. They got to get back on track with the one I put in front of them. You may be promoting that singular pathway to recovery, may not be acknowledging that there are significant barriers to treatment this patient has. By the way, we also have to accept that as a clinician, an unchecked bias can also influence the actual intervention I select. I think we've seen this most manifest in our industry's, I'll say, historical response to harm reduction, because we're making some good progress, but there's been really good, I'll say, recent, incredible positive movement when we talk about harm reduction acceptance. But in general, we've been really slow to welcome harm reduction into the fold of the recovery community. There's been a lot of misinformation, a lot of fears that's contributed to our skepticism. There's a lot of definitions on harm reduction out there, and some focus really heavily on public health, the idea that we want to reduce this certain threat in our community. And in fact, we tend to see more focus on harm reduction during times of public crisis, right? Like the surge in infectious disease, or something we're seeing, recently with the opioid epidemic going up and down in overdose rates. So we can really think about harm reduction as a strategy for an individual, not just a public health concern. There's a strategy that can be used that's not just to help protect the public, but to help protect or maintain safety around an individual I'm working with and treating. I really like this definition you see here on the screen of harm reduction. This comes from SAMHSA. It says, harm reduction is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve the physical, mental, and social well-being of those served, and offer low threshold options for accessing substance use disorder treatment and other healthcare services. So recap about this definition. To me, my short takeaway is one, it's about direct connection with people who use drugs. Two, preserving life and improving wellness. And three, offering hope and opportunity. When you look at the history of SUD care and some of the history in those definitions I talked about earlier, it was really historically founded on abstinence-based approaches only. So that means the ultimate goal, the only goal that we had was complete cessation of substance use. So our sole measurement of success in treatment is, are they using? Are they not using? And so out of that historical context, the treatment community has been a little slow to embrace harm reduction. I think to some degree, there's still a good percentage in our field that view harm reduction strategies as a form of enabling. Sort of like, well, making your kids put that seatbelt on is going to make them more prone to get into an accident. Giving those patients on the streets condoms is going to drive their behavior to be more sexually active. Giving them access to safe injection equipment or fentanyl test strips will encourage them to use. Is any of that really true? So excuse me, in the spirit of checking our blind spots, I want to share a tool with you. Hopefully you've heard of it, but if not, I've added it to the handouts for this training, and you can also look it up. It's in free public domain. There's a tool called the Harm Reduction Acceptability Scale, HRAS. It's a validated tool with 25 Likert questions that measure an individual's open-mindedness to harm reduction concepts and practices. Now, lower scores reflect greater open-mindedness to harm reduction. Now, this is just a short webinar, so I'm not going to go over it with you, but if I was, with you in person or we did a longer training, we would actually have each person on the team or each person in the training kind of go through the Likert questions and kind of measure our responses and share them openly and honestly with each other. And that kind of takes the veil off of some of these secret attitudes and behaviors that we're just not sure. We don't know sometimes, and that's okay. It's okay to not know, right? So this really is an awareness building tool. It can help drive your awareness. Now, why in the world is Samson talking to you about harm reduction when we're supposed to be talking about progressing forward in relapse prevention? Okay, to understand the connection, I think it's really important to understand how individuals with SUDs actually feel and think about their substance use. Let's look at some of the data. So once a year, SAMHSA does that national survey on drug use and health. I hope you've heard of it. It's a nationwide study that gives the field up-to-date information on drug use throughout the US. So one of the things that they look at is what's called the perceived need for substance use treatment. Now, this what you see on the screen is from the most recent survey in 2021. In 2021, they estimated that in the previous year, 46.3 million people ages 12 or older met the criteria for substance use disorder. Now, of those roughly 46 million, they estimate that 94% did not receive SUD treatment. Of that group who did not receive SUD treatment, 96.8% said they didn't get treatment because they did not feel they needed treatment. Now, what if we look at just this tiny little sliver of folks that I'm pointing to here? This is the folks, 2.1%, that recognize they need treatment but did not make any efforts to get treatment. Now, when we zoom in and look at that little sliver of individuals who acknowledged a need for treatment, they didn't make efforts to get it. 36.7% said the reason they did not seek treatment is that they were not ready to stop using. Now, to me, what this data illustrates is to me it's kind of something we already know about SUDs, but there's this significant lack of insight in someone with an SUD, right? There's an inability, or some call it a diminished ability, to recognize the significance of the problems of my own behaviors. We've had kind of a clash in the field when it comes to that. You do have a problem. I don't have a problem. You do have a problem. I don't have a problem, right? I mean, that's kind of what it looks like. Um, and yet it's a symptom of the disease. Now, that substance use disorder we've talked about is the disease of the brain. It includes parts of the brain that deal with motivation. So, as an addiction treatment professional, we really should anticipate that many of the folks we work with, they have difficulty acknowledging or recognizing what the ASAM calls need for change, right? You remember, hopefully you've assessed someone's need for change. Many of the people we need to be working with and attracting into treatment, they feel the same. They recognize that there's a little bit of a barrier. We have to be willing to meet them where they're at. Now, sometimes our attitudes and our response, they don't reflect this data, right? We hear things in our field like, well, they're just not ready yet. They're still in denial. They're not ready to surrender to their higher power. They haven't hit their rock bottom yet. The problem with dismissing individuals as not ready is that we're really dismissing 40 million people with an addiction-related disorder. It's important that we stop viewing readiness as a precursor to change. We've got to start viewing it as an integral part of the change process. It's not a light switch, right? On, off. So we have to really be willing to work with individuals who use drugs, even when they don't want to stop using. So because of this, harm reduction is really an essential weapon in our arsenal of interventions for working with people who use drugs. It's important to embrace harm reduction as an opportunity to preserve lives, to keep folks safe, to help them move forward on the continuum of wellness, right? Now, I really love this quote. I gave you a few quotes earlier. I'm a quote junkie. I keep them together and hoard them to inspire me or keep me laser focused on what I'm working on. It's important to meet people where they're at, but not leave them where they're at. This quote embodies the heart of harm reduction work. Now, I want to take a quick moment to glance at some of these highlights from the last 10 years of research. So this is another a systematic review of outcome measures. So I've got the citation here, and of course it's in the references page. For the sake of time, I'm just going to let you look at this on your own. I'm not going to read it to you, but I do want to point out one thing, right? Historically, research showed that longer time in treatment is related to better outcomes. You've probably heard that before, right? Most present studies, however, show that it's not necessarily the duration of treatment, but it's rather the characteristics of the programs that provide longer treatment stays. Now, I've got a list of those characteristics that provide more successful outcomes or longer stays in treatment. Now, by the way, longer stays in treatment, we're now realizing in addiction treatment, is connected to successful treatment outcomes because they're not overdosing. We've equated patient retention with patient safety, which also leads to patient progress. We're no longer trying to examine whether or not there's a cure, right? We're trying to examine safety elements that promote someone's wellness and recovery, right? So we've kind of expanded our understanding in the system of care. Now, speaking of our system of care, I'm going to turn this over to one more video. You may have heard of Joe Powell. He shared some information with me about our system of care. I'm going to let him talk about another critical element in our system of care in this short video.
Well, great to be here. My name is Joe Powell, and I am a young person in long-term recovery. And what that means is that I haven't had a drink of alcohol in 33 years and haven't used any opiates since January of 73. And it's only because of recovery that I'm able to be a father and a husband and a lifelong learner and a servant leader and the president and CEO of APA, the Association of Persons Affected by Addiction in Dallas, Texas, for 24 years now.
That's awesome. Yeah, we're really lucky to have you. Your background is critical on this topic, so I'll just start and jump right into it. You know, the topic is the stigma of relapse. Just in general, for recovery, what is your perspective of the stigma of relapse? How do people look at a return to use or relapse in a negative way, or in a way that promotes negative stigma, unfortunately?
Well, I think that's comes from just old ways, old stigma that's been around for a long time. That people just need to pull up on their bootstraps. You know what I mean? As far as if you got bootstraps, I don't know who have bootstraps nowadays, but when you talk about just quit doing and so illness, you really is primary in the body, so it's not something that you could just quit. That is part of illness that's in the body. But I think that long time for years, people just think that you can stop whatever it is when it comes to alcoholism or addiction with any substance. And that's something that once it really takes a toll and cuts that path in the brain, that path, and I know that for me, it was a path of pleasure first, and then before it became an addiction, right? And it was just use and then pleasure and then moving into a misuse or abuse and then addiction, to where I was really dependent on it. And so I know that I couldn't stop. Many times I said I'm gonna quit, and couldn't quit. Or I'm gonna say I'm gonna stop drinking and couldn't stop drinking, what I mean? So I couldn't quit, couldn't stop, And so, but I think that, the stigma even had me believing at one time that I could just stop on my own by myself, and that somebody just need to threaten me and say, yeah, you need to stop. I even remember right quick that when a judge gave a person 25 years for relapse in prison. And so, the judges didn't have a clue anything about the disease of addiction.
What does a professional in recovery need most from their colleagues who are not in recovery, from their employer, from their healthcare agency? What do they need most?
I think they just need support, and those resources just available to them, but mainly support and really knowing that who are they to them. So it's like, who are we to each other and who are we to others? I just so happen to have a good friend of mine who was really taught me about peer-to-peer, who was a psychiatrist, who I met him when I got sober, and they said, hey, you got to get a sponsor, you got to get somebody to connect with. And I didn't know he was a psychiatrist. I probably wouldn't have asked a doctor to help me when you're trying to get sober. I don't trust nobody. And that's what happens, what causes relapse. And how do you prevent? Because who do I trust, right? Who is it that I can really talk to? And that is the challenge so much for so many people. But yeah, Dr. Deere was the one that was there for me for 30 years, right, before he passed. And that was so cool to have not only a doctor, but just peer. He didn't treat me like a client or patient or anything. We were just buddies, on a daily basis, and he had me to call him every day. He told me for him to support me, I had to call him every day. I said, I ain't never called nobody every day. I ain't never called my mother every day, and but today, because of my recovery, I call God and I call a lot of people, and of course, even at work, people call on me. They want support. The other thing is, and a good example of is I had a clinic, an organization, and it actually was a clinic, FQHC. It was actually told me, hey, you know what, Joe? We would like your organization to be our EAP organization, because a lot of people at work does not trust, back to the trust factor, do not trust EAPs, or don't really trust, how do I go into this place? Is everybody going to see me? You know what I mean? And it's hard sometimes for us to really to be right there in the workplace and get the support in the workplace that we need.
All right, so that was a lot of info. I'm gonna speed this up a little bit and make sure you got a few things really, really important. A few things he shared: embedded historical stereotype in addiction treatment, that it's still just the start-stop, a lack of an in-depth understanding of a chronic disease model, that chronic disease requires chronic care management, right? Which means there's going to be episodes of care throughout that individual's journey. Substance use was originally solving something. It started as pleasure, remember risk reward, and professionals in recovery need support. Now, he gave a few examples that I loved. He talked about healthcare agencies, even a hospital, or even in the tech sector and other agencies using RCO or a ROSC, a recovery-oriented system of care, or a recovery community organization as their preferred EAP. So that means someone has a safe and anonymous place to go to continue or begin their recovery work if something happens while they're on the job. Now, Joe, website is recoveryiswhy.org. I have really no affiliation with them other than that I'm a fan. It's APA, Associations of Persons Affected by Addiction. They're the first RCO in Texas that received national accreditation from the Council on Accreditation of Peer Review Support Services. So they've got a lot of great information about how to implement peers. But I got 2 more videos for you, so I'm going to shut up and share this one for you. Some interesting info.
I just thought maybe if you could start by just introducing yourself to everybody, and then if you could, my first question is, are there ADA violations to consider in a case where a professional in recovery experiences a return to use?
Okay, well, thank you so much for the opportunity to talk to people today about the Americans with Disabilities Act. Before I answer your question, though, I did want to talk very briefly about the Americans with Disabilities Act and say this: the ADA is clear. People with addiction are people with disabilities. And under the ADA, people with alcohol use disorder and substance use disorders have many protections at work, in accessing health care, in corrections, in the courts, and in treatment and recovery, just to mention a few. My name is Oshie Harrison, and I am the project director of the New England ADA Center. We are one of 10 ADA centers regionally located throughout the country to answer the public's ADA questions confidentially and anonymously. So, Samson, your question about the ADA is really touching an area where the ADA does not have protections. It is an exception. But to answer it, if an employee is currently engaging in the illegal use of drugs, that employee has no protections under the ADA, no protections under the employment section of the ADA. And that employee can be terminated without the employer violating the ADA. So this applies to employees in recovery who have returned to use. This applies to the casual user of illegal drugs. And the reasons are that the ADA is federal law, and it is tied to the Controlled Substances Act. So for people with substance use disorders, they have ADA protections when they're in recovery, but not when they're engaging in the current illegal use of drugs.
Thank you so much, Osi. So one more question I was thinking about. What should treatment agencies do to improve supportive mechanisms for professionals in recovery who may have experienced a return to use?
Okay, well, we all know that relapse is a part of recovery. Just because the ADA does not extend protections to an individual engaging in the current illegal use of drugs, that does not mean that the employer is required under the ADA to terminate the person or take any adverse action against the employee. So the employer may choose to grant medical leave for the employee to seek treatment. The employer can also choose to make very clear that any further relapse could be cause for termination. It's called the last chance agreement. But such actions are left to the discretion of the employer. Now, a person in recovery struggling to stay in recovery and before engaging in the illegal use of drugs has protections under the ADA. So protections like what the ADA calls a reasonable accommodation, and it could be a change in their hours so that person can get their medication or they can get to extra meetings. And it could be a leave of absence so that person, if needed, can go and get treatment. This is the opportunity for ADA protection.
All right, so I know that was a lot of information. Listen, if you're getting legal advice from me, you're in trouble. All right, I'm an LPC. I know our business very well in clinical services and clinical treatment of addiction and evidence-based practices. But Dr. Oshie Harrison, this is her life, right? So one thing she shared with me that is really important is we talked about how words matter in our field. Words really matter in the legal sense. If you remember her quote earlier, about if someone is under they're using illegal substances as an employee, it says that the employer can terminate. So again, that's a stress on language. It doesn't say that they have to, right? So that's where she shared some information. So quick takeaways. Just because the ADA does not extend protections to someone who's engaging in the current illegal use of drugs, and I stress that because it's illegal under federal. So if cannabis or a substance is legalized in your state, that may not qualify for ADA protections. You may need to look and see if there are state protections. Now, again, that employer, instead of termination or having an adverse reaction, they can grant medical leave for treatment, establish a last chance agreement, or as Joe said, provide EAP support. So wrap it up into a benefit package of being an employee with that company. We're talking about making systems corrections, right? Making upgrades or updates to our system so that we can actually live what we preach. But before we get there, let me make sure you've got her contact info. She left it here. It was so kind of her. Dr. Oshie Harrison has an email, cell, and a free ADA inquiry call number so you can call. They are the experts. They're really the ones you want to reach out to things like this. So with no further ado, last video, let me turn this over to Dan Griffin, and then we'll close out with some recommendations and next steps.
Well, hi, everyone. Dan Griffin. I have spent a lot of time looking at the intersection of male psychological development, trauma, relational competence, all in the context of recovery for addiction, mental health, and trauma.
Thanks, Dan. And yeah, so for me, I invited Dan because Dan really helped sharpen and shape my perspective, my lens in the area of trauma and substance use disorders. So my first question is, in that context, we're talking about the stigma of relapse. And we're in a system of care where more than half of our professionals themselves identify as being in recovery. What do we need to take into consideration when we're looking at trauma and systems and our professionals who are in recovery?
Well, as a field, I think we've done an amazing job lately, really beginning to evolve and address trauma. And, it's amazing to me now where I go to conferences and I hear all this conversation around trauma. So something is shifting, and I think that's really wonderful. What we have to remember is that if 50% of the people that are providing the services are in recovery, then that means they probably went through services of some shape or form some time ago, and chances are those services were not trauma informed and did not help those individuals deal with the trauma. So what we have is what I like to say is a traumatized field. And in fact, we have a traumatized field working with traumatized clients, and then we're sending them back to traumatized communities. So like trauma has a thread through so much of it, this question of like, well, how do we take care of ourselves and each other, right? Because to me, there's an irony in the fact that a field that is predicated on caring for others can sometimes struggle so desperately with caring for ourselves and caring for each other in a systematic and systemic way, as opposed to the clients that we serve. And, one of the things that I talk about with programs, like if we work with a program and we do consulting, we'll often tell them look, if you want to be trauma-informed care, we're going to do an assessment. The last thing that we're going to look at are your services. It's everything else. And I think this movement toward trauma-informed care has been hyper focused on the services we provide and not necessarily the environments and the systems that we create. And as a result of that, I think we miss the traumatized workers. We miss the re-traumatization that a lot of our staff have as a result of working with people with significant trauma and addiction and mental health. And then, quite honestly, sometimes through no fault of their own, but sometimes because of neglect, because of a lack of professionalism and safety, there are traumatizing experiences within the system that people are working in, that even programs, it's been amazing to me, right? There are programs that can say, oh yeah, we're trauma informed. And then like you go visit them and the staff are like, they are terrified of the idea of speaking up and talking about what's happening in the organization. That's the first clue that you are not trauma informed. Like that is the shift that we have to make of like saying like trauma informed is like, hey, you know what? We're all in this together. We're all imperfect. We don't have to let the shame or perfectionism of thinking we have to be the perfect program. We can't have, you know, problems in our program. That somehow means that we're not doing things well. And then you see that kind of family systems component playing out in organizations, and then people don't feel safe talking about their own struggles. They don't feel safe taking care of themselves. You know, when we work with programs, we advocate mandatory vacation policies. Don't tell us about the massage therapists you have for your clients and the yoga services you have for your clients. How about for the staff? Do you have, you know, breaks set aside always for the staff to take care of themselves? Do you have support meetings? How do you structure the staffings? All of that is, I think, about creating a safer, more loving, more supportive, more collaborative, more connected system. And in that space, professionals who are struggling are, one, going to be more cared for. They're going to feel more comfortable sharing that they might be having a difficult time. The system is going to respond more lovingly and more supportively to that. So all of that, to me, like that's when we're really truly being trauma informed, where the attention and the services and the support we give to the staff and to the organization as a whole are equal to that which we're giving to the clients.
Ooh, if you're from the South, you got chills, right? You were kind of like, yes, amen, Dan. I dropped Dan's contact info here because, I mean, he is incredible, like such a great resource, a great expert in the field. The first thing he said that really stood out to me was when he goes in as a consultant to assess whether or not a program is trauma-informed, the last thing he looks at are services. And yet I will admit in the field, I don't know about y'all, but we assess whether we're trauma informed based on the services we provide our patients. That's the first thing we think about, not the last. He's really focused on the environments that we create, the system of care, right? Remember that why I shared with you earlier? So some of the takeaways: we're a traumatized field working with traumatized people, sending them back to traumatized communities. That irony that he mentioned, that a field that's predicated on caring for others can sometimes struggle so desperately to care for ourselves. And that trauma informed is really focusing on the environments and systems we create. So let's talk about, okay, what now? Well, first, we really have to remove some of these myths. And we've got to kind of destigmatize or kind of unpack some of these things that are wrapped up into our field. So here are the top 5 most common myths about relapse that I see in our field, and you've probably seen it too. One is it's all about willpower. Really? I mean, if addiction were as simple as putting down the drug of choice and not picking it up again, there wouldn't be so many conferences. There wouldn't be an IRETA webinar. Think about what Joe shared earlier. Remember how substance use alters the way that that brains work when we're discussing the neuroscience, the relapse of addiction. At the end of the day, someone with the greatest willpower in the world can feel completely helpless with a substance use disorder. What about myth number 2? Hitting rock bottom is a prerequisite for sobriety. I mean, what is that even? What is rock bottom, right? I mean, does it get more vague than rock bottom? I mean, we've now had 2 vague moments. Okay, so loss of job, is that rock bottom? I lost my spouse, is that rock bottom? Lost kids, 12th time in the ER being told that I almost died. What is rock bottom? How do we measure that? At the end of the day, the data that's been most consistent is that those who get the help the soonest and earliest tend to stay in recovery programs the longest, right? They have higher success outcomes. So the myth that rock bottom is a precursor, it's actually keeping people out of treatment and keeping them away from coming to those who can help. Quite frankly, I think as clinicians, sometimes the myth about rock bottom is more an excuse for our lack of patience with those people we're helping. Sometimes, let's be real, we often say, oh yeah, you keep slipping because you haven't hit rock bottom, because we have not exhausted our efforts, our referral channels. We have not said, well, maybe we should try a different path of treatment, maybe a higher level of care, maybe a different level of care, maybe in a different environment, maybe a different team. So myth number 3, if sobriety isn't your ultimate goal, then you're not in recovery. Look out for this one. It's a little complicated. Of course, y'all, of course, the most ideal outcome for all patients that we care for is we want them to be and stay in recovery. And yes, that includes sobriety. So we don't go to the extreme of demonizing, yes, the most ideal outcome. We just want to expand our perspective of that journey. We want to make sure we understand that 22,000 people dealing with the exact same symptom can present it 22,000 different ways. And their journey and episodes of care can be very different. At the end of the day, our main goal is not about sobriety necessarily. It's about keeping someone safe and keeping our communities alive, ideally out of jail, long enough that they can access treatment that works for them. That's the goal, is to get them alive long enough to get to the treatment they need. Myth number 4, relapse is a failure. Now, remember, we talked a little bit about this. No, it's a part of our definition, part of the diagnosis. Sometimes that diagnosis or that relapse is a symptom that validates they're in the right place. It validates their diagnosis. Now, that return to use sometimes could either say, oh, you're in the right place. Okay, that's what we expected, right? Or it could say, hey, you're in the right place, but maybe you need something more. Maybe there's a need of MAT. Maybe there's an adjustment to the dose and dosing schedules. Maybe there's an adjustment to the amount or frequency of counseling you get, or the type of counseling you get. Speaking of the MAT, what does this say above me? This is real recovery. Yeah, so myth number 5, that MAT is not really recovery. You see this tagline at BHC. Yes, it's an intentional, simple flatback. Yeah, I did that. But okay, so this is real recovery too. Someone who's using medications to help manage withdrawal symptoms and support return to use or relapse prevention, thanks to decades of validated medical science, has saved countless lives. We don't disparage a person for taking insulin or blood thinners to control a disease, and we don't decrease their dose to punish them for stepping outside of their behavioral recommendations for successful treatment. So we've got to start dispelling these myths. Now, these are just three more unhelpful, untrue misconceptions that we've got to dispel. There's a lot out there, right? But we've got to be a part of removing some of these barriers, this stigma that we've kind of contributed to in our field. Now, some of the mistruths develop this really linear viewpoint of recovery. The idea that there's a clear starting point and a clear end point, that active use at the starting point, there's abstinence at the end point, right? But in this context, we see now that relapse or return to use is a reality in the recovery process. It's not a linear journey, right? Not everyone starts at the starting line. Not everyone ends up in that ending line. We have patients that are in their 70s that have been receiving MAT for years, and they've maintained stable housing. They've maintained a job. They've maintained their family. They've won back their relationships. So are they not in recovery too? Because that looks like recovery. It may not look the same, but it's important to understand that folks start on different points of the spectrum, right? Remission from SUD is characterized by the absence of diagnostic criteria, not the absence of substance use, right? There are so many paths, so we really want to focus on how a person can achieve recovery and remission in their path, in their journey. Now, again, I want to be clear, abstinence from substances is often the ideal outcome, right? And we don't want to deviate too far from that, but we want to make sure we're not saying that it's the only outcome, because then we're now back to program-driven treatment and there's no individualized experience, right? Now the SAMHSA definition of recovery is important to remember here. So, take a look at that definition: a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Relapse, in the context of a non-linear recovery process, it's going to take different shapes and meanings. So how we respond to a relapse or return to use should also take different shapes and different responses and different meanings. It should be based on the concept of meeting someone where they are. That includes using harm reduction strategies for individuals who are not yet ready to discontinue their drug use, because we're trying to keep them alive, support and promote their safety. A progressive paradigm, or maybe I should say a more up-to-date paradigm for relapse, has to begin and end with understanding that relapse is an accepted norm, an expected norm. It's a part of recovery. Remember, we still hear stories where both patients and professionals in recovery experience not just societal backlash or close relationship rejection and negative stigma, they also experience this from medical care providers, from treatment providers. So this return to use that we all pretend we know is going to happen, let's talk about what to do when it does. Now, understanding that it's an expected norm, I like, when I work with my patients, to take the zoom out of relapse, take it off of the return to use, off of the event, and focus or zoom in into the precursors. So some people in CBT call this a lapse versus a relapse. 3 lapses to keep in mind. 1, a lapse in patterns of thinking. 2, a lapse in patterns of feeling. And 3, a lapse in patterns of action or behavior. Years ago, right, a lot of counselors or sponsors would start some of their preliminary discussions with a patient with a substance use disorder by saying, hey, what are you going to do when you're sitting in that bar, you got that drink in your hand, or when you're sitting on that corner and you got that syringe? They're really focused on relapse prevention, on how to intervene in that tight, tense moment. Well, you know what we found out for most of our patients? They're going to use because it's too late. We have not trained them on how to respond to the precursor. So the difference is, here's an upgraded question. What are you going to do when you're 5 years in recovery? You've maintained and sustained even a level of sobriety for long enough to be a worker in the field. So you're a professional helper in recovery. As you worked in this field, you've climbed up the ladder a little bit, and you're really excited because now you're a clinical supervisor, a manager, maybe just a counselor with a full caseload who also manages and helps and supports new folks coming in. But as a professional in recovery, the last 2 years have been really stressful. And you noticed that you've deviated from your action. You noticed that now when you drive back home, you sort of drive by this corner just to see if that person is still there. You drive on a different exit and you go by this cousin of yours who you know used to mix and sell. Your lapse has been an active lapse, but not a relapse. What if we trained people to respond at the moment of lapse? What if we created alerts, cognitive alerts for how to react and respond to a drift? I notice that I'm getting more snappy with my kids. And you know what? When I used to use, I was really snappy, right? That's a lapse, a feelings lapse. So there's a lot of information on how to guide your patient to learn from a lapse or to identify a drift, analyze that drift, and build the treatment in that direction. But as a system, there are some strategies we can't forget. We have to make sure that in our system of care, we've created language, policies, and even clinical forms that give copies of things to the patients where they take their treatment with them and they can start building it within their support system. Part of CBT and responding to relapse or return to use is building up that person's support system and using counseling to rehearse those conversations. So a conversation like, here's a picture or a collage of something that's important to me. They share it with the counselor, then they share it with someone in their community. And then, of course, halt, hungry, angry, lonely, and tired to build that situational awareness. But let's make sure not to forget stigma. Here's an example of 4 reactive responses. I'm going to share 4 affirming responses. So sometimes someone returns to use and we say, just give up. There's no use in trying to change. You have to start all over again. You don't deserve this medication. My supervisor, the chief medical officer of BHG, Dr. Ben Nordstrom, has this quote here. There's a misconception that harm reduction is facilitating people's drug use when it's actually about keeping people alive long enough to change their motivation to get into recovery. So instead, some affirming responses. I'm glad you survived. Let's get back to work. You're still present. What triggers caught you off guard this time? What triggers did you see coming? Which ones did you not see coming? Hey, you're getting better at recognizing lapses sooner. That means you're growing. Your upward spiral started today when you showed up to treatment. Now, one question we have to ask ourselves, if we're not in a program that has MAT or we're in an abstinence-only program, that's fine. I mean, every single network of recovery is necessary for our journey, for our community, for our industry, right? But do we discuss all treatment options with our patients for shared decision-making? Because think about it. If I don't discuss MAT with my patients who have significant recurring return to use, what are they going to do? Google it? Ask a friend? I mean, where do you want them to hear about it from? So what I'll say is it is a challenge for all of us that if we're working with people who are actively using or who have a return to use and we're trying the same thing over and over again and not getting the results that either of us are looking for, whose responsibility is it to introduce MAT as an alternative option or as an additional path of recovery? And by the way, those in MAT programs, it is important that we're also talking about inpatient stay if someone has experienced recurring lack of safety in their life. So we've got to know levels of care and additional treatment options beyond what we provide. Here's a guided discussion tool, but the last piece to remember is it starts with us. You can influence change in your community, in your state, in your program by introducing what the Department of Labor has rolled out called a recovery ready workplace. There is a link here to the Department of Labor. I also added a recovery ready workplace employer guide that you can read through and take to your HR team. It's a way for us to adjust just a few policies and benefits for our care providers to show that we care about the mission beyond the communities we serve, but also the workers who work with us, the systems we create, that we care so deeply that we're willing to brand ourselves a recovery-ready workplace. And there's a way to do it. It's an awesome system. All the information is there on the Department of Labor website, but it's really about designing the system that is safe for people and professionals in recovery, not just to work at, but to dwell in, that work and that life balances with a model that supports the disease we all recognize. I want to encourage you to visit this Department of Labor website to consider being a champion of change in your location. If you're looking for an example on how we've incorporated some of this information at BHG, you could scan the QR code or click the link and go to bhgrecovery.org and learn about the integrated dynamic care model. It's a research white paper that talks about evidence-based strategies for how to incorporate some of this in your program. IRETA, thank you all so much for this opportunity, for this time. As you can see, I'm super passionate about this. And yes, it started at a place of anger when I was upset about losing one of my mentors too soon. But I will tell you that we've made so much progress. All the ingredients we need to improve our system, we have them in the cupboard, right? So we just need to get those ingredients, pull them together, and move forward together. Thanks, y'all. So I think we may have a few minutes for questions. Sorry, I went to the end. Here's the references slide.
Thanks so much, Samson. Yes, we do have a few minutes for questions. If anybody would like to submit those through the chat or Q&A box. Meanwhile, we're just getting a lot of comment, which I'm guessing you're seeing a lot of positive comments thanking you for the presentation.
No,
Yes.
thank you all. Thank you all.
Oh, I'm getting a few questions about PowerPoint, or if you'll be getting the PowerPoint slides. Yes, the PowerPoint slides will be available. I'll be sending them out with our reminder about the survey, as well as posting them with this recording once that is up on our website, which you'll get an email about as well. All right. Well, it doesn't look like any questions, just lots of positive comments.
Yeah, someone said the QR code, so I just went back to that here on the slide.
Oh, perfect, perfect.
I'm trying to follow the chat box. There's a lot there.
Yeah, I'm just making sure nothing. Somebody asked where to get trauma-informed counseling in New York. Do you happen to have any
Oh my gosh. So
information on that?
yeah, great question. So Linda, I'll say reach out to me in LinkedIn. I mean, I don't want to say, oh, go to this provider. But I was in New York as a practitioner and as the director of training and professional development for Phoenix House for a number of years in New York. And so I got a chance to meet a lot of exceptional counselors and teams and programs that provide trauma-specific treatment. So evidence-based treatment for PTSD or trauma-related disorders. So Linda, if you want to connect with me on LinkedIn, I'll send you some contact info of people you could refer to in New York.
Great. All right. If the attendees would like to stick around for just a minute, I'm going to go over some housekeeping as far as how to get your CEUs. Thank you so much again, Samson, for such a great webinar. We would like to remind all participants that a PDF of today's PowerPoint, along with the recording of today's presentation, will be uploaded to the webinar library located on IRETA's website sometime within the next week. Once we have these resources posted, a link will be sent to all of today's webinar registrants. I now want to remind you of our evaluation and CEU process. You will receive several follow-up emails from us. The first email will include a link to the evaluation, and the second email will include step-by-step instructions on how to obtain CEUs. Please note that it will take up to 48 hours for your CEUs to become available because we have to cross-check your attendance records with WebEx. We would like to specially request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address is info@ireta.org. And with that, I will conclude the webinar. Thank you so much, everyone. Have a great afternoon.